If you look at a satellite map of a massive city at night, it looks almost alive, right?
Yeah, absolutely.
They have these glowing highways and the rhythmic pulsing of traffic lights. It's like this invisible hum of electricity keeping millions of lives moving.
Right. And it's a highly synchronized system. I mean, every single component depends on, everything else functioning perfectly.
Exactly. But what happens when that grid fails?
Mhm.
Like a water main bursts and floods a subway tunnel, or the central power station trips and the entire skyline goes dark.
The whole city goes into absolute crisis.
Right. And today we are looking at the ultimate, most sophisticated city grid in existence, the human heart.
We have a massive stack of sources to go through for this deep dive. We're looking at clinical medical guidelines, intensive nursing manuals, and even some raw body cam footage of a real cardiac resuscitation.
It's intense stuff. And the mission today is to completely demystify what happens when this biological grid goes offline for you, the listener.
Mhm.
Because if you don't know exactly what kind of failure you're dealing with, well, your emergency response might actually make things worse.
Right. Medical terminology can definitely sound like a foreign language, but we're going to break it down. We are going to look at the heart as this incredible but very vulnerable machine of plumbing, electricity, and mechanics.
So to start, I noticed a major misconception that popped up constantly in our source material. Specifically, they referenced an American Heart Association video and the very public incident with football player Damar Hamlin a while back.
Right, the Damar Hamlin case.
Yeah. People use the terms heart attack, cardiac arrest, and heart failure completely interchangeably. They just lump them all together as, generic heart problems.
They do, but clinically speaking, treating those three things as the exact same event is a dangerous oversimplification. Our source material from Health Decide actually breaks these down into three fundamentally different crises.
Okay, let's hear it.
So first, a heart attack or myocardial infarction is essentially a plumbing problem. Blood flow to the heart muscle is physically blocked by plaque or a blood clot.
Right, so the pipes are clogged.
Mm-hmm.
Then you have cardiac arrest, which the source describes as an electrical problem. The heart malfunctions and just stops beating entirely.
Exactly. The electrical signals turn chaotic.
The heart might go into a systole, which is a flat line, or ventricular fibrillation, where the ventricles just start quivering. The visual they used for a heart in VFib was that it looks exactly like a bag of wriggling worms.
Yeah, it's a super vivid image.
Okay.
And it's not pumping a single drop of blood in that state. Finally, you have heart failure, which is a mechanical problem.
Mechanical, right?
Over time, the left or right ventricles weaken or become too stiff. They just fail to pump effectively. And because that mechanical pump is weak, fluid starts backing up into the lungs, causing shortness of breath, or it pools down into the lower legs and feet.
Okay, let me try to map this out so I have a clear picture in my head. Let's look at the heart like a house.
I like that analogy.
So a heart attack is like a clogged pipe under the kitchen sink.
Yeah.
Cardiac arrest is a total blackout at the main circuit breaker. And heart failure is the basement sump pump that's just slowly giving out over years of use.
That analogy works perfectly, but to take it a step further, you have to understand how they trigger one another.
What do you mean?
Well, that clogged pipe, the heart attack, can cause so much tissue damage that it short-circuits the electrical system, and that leads to sudden cardiac arrest.
Oh, wow.
Or if you survive the clogged pipe, the resulting tissue damage permanently weakens your mechanical pump, leaving you dealing with a long-term heart failure.
Knowing these differences isn't just an exercise in medical vocabulary for you. The emergency response for each of these scenarios is completely different. I mean, you don't call an electrician to fix a clogged sink.
Exactly. Let's look at the plumbing failure first. The heart attack, or myocardial infarction, the pathophysiology detailed in the Simple Nursing and Dr. Matt and Dr. Mike sources is really fascinating.
Yeah, they talk about atherosclerosis, right? Plaque building up.
Right. Plaque, which is primarily cholesterol and fat, builds up on the inner walls of the coronary arteries. But the critical danger isn't just the narrowing of the pipe. It's what happens when that plaque ruptures.
Wait, why would it rupture? Does the pressure just build up too much?
Sometimes it's pressure, sure. Other times the plaque capsule just degrades and tears. And when it does, it exposes the fatty, necrotic core of the plaque to the bloodstream.
And the body doesn't like that.
Not at all. The body's immune system sees this sudden exposure as an injury, much like a cut on your arm. It panics and sends platelets to scab it over. That scab forms a blood clot rapidly.
Right, and inside a tiny coronary artery, it completely seals off the pipe. which drops the oxygen supply to that specific part of the heart to zero.
Exactly. And this is where the clock really starts ticking.
The math from the sources on this is genuinely terrifying. When that oxygen is cut off, over 500 heart cells die per minute.
500 a minute.
Yeah. And within just 45 minutes, that tissue reaches irreversible necrosis. It's dead forever. The phrase they use is, minutes equal muscle.
Which is why recognizing the symptoms immediately is your only defense against that clock. The classic symptoms are well documented. Left substernal chest pain, pain radiating down the left arm or up into the jaw, and diaphoresis.
Diaphoresis, that's the profound cold sweating, right?
Yes. It happens because the body's sympathetic nervous system is dumping massive amounts of adrenaline in an absolute panic over the lack of oxygen.
But the sources also spend a lot of time warning about something called silent MIs. I saw that they frequently happen to women who often present with atypical symptoms.
Right, like extreme fatigue or indigestion rather than the classic chest-clutching pain.
Yeah. But they also highlighted diabetic patients as being incredibly high risk for these silent attacks.
Diabetic neuropathy is the main culprit there. Over years of uncontrolled high blood sugar, the excess glucose crystals physically damage the microscopic nerve endings throughout the body.
So the sensory nerves are literally destroyed.
Exactly, meaning the patient physically cannot feel the agonizing chest pain even as their heart muscle is actively dying.
But wait, if someone is sitting there with neuropathy, feeling absolutely nothing while their heart cells are dying, how do doctors even catch it? How do you diagnose a crisis that's invisible from the outside?
Emergency departments rely on two gold standard diagnostic tools that don't depend on the patient's pain scale at all. The first is the EKG, the electrocardiogram.
Which measures the electrical footprint of the heart.
Right. Doctors are looking for a specific wave pattern called ST elevation. If they see an ST elevation, often called a STEMI, it means there is a full thickness blockage. The entire wall of the heart muscle is dying.
Wow. And what about a partial block?
An ST depression, or NSTEMI, indicates a partial block.
Okay, got it. And the second tool is looking for biomarkers in the blood. I was reading the nursing.com source, and they specifically highlight a protein called troponin I.
Troponin is the ultimate red flag. It's a structural protein that basically acts like the mortar holding cardiac muscle fibers together.
So when those heart cells die from lack of oxygen, their cellular membranes burst open.
Yes, and that spills troponin directly into the bloodstream. A normal troponin level is practically 0. If a blood test comes back with a troponin level over 0.5, it is absolute, undeniable confirmation that heart tissue is currently rupturing and dying.
So that's the cellular disaster happening inside the chest. But what does it actually look like when those cells hit the breaking point and the whole system crashes?
It's intense.
Really intense. I was watching a YouTube video from a channel called Dr. Sharkey, and it is raw, unedited body cam footage of first responders arriving in a living room. They're treating a young woman who has gone into sudden cardiac arrest.
Her electrical system has completely failed. To an untrained eye, the video looks like pure chaos. You have wires everywhere, people shouting numbers, alarms going off.
It looks completely improvised, but you pointed out earlier that it's actually incredibly organized when you know what you're looking at.
Oh, definitely. Every single person in that room is executing a specific role based on advanced life support algorithms. First and foremost, you see relentless, high-quality chest compressions.
Right. The Dr. Myro's source points out that when the heart stops, those compressions are literally taking over the mechanical pumping of the heart.
Exactly. The paramedics are manually squeezing the heart between the sternum and the spine to force blood up to the brain.
And they eventually bring in the defibrillator to analyze the rhythm, right? Looking for a shockable rhythm like that V-fib we mentioned earlier.
Yes, to try and reboot the circuit breaker.
But there were some gritty details in this footage that really blew my mind. At one point, they place a breathing tube and attach something called a capnograph.
Right. Capnography measures the amount of carbon dioxide coming out of the patient's mouth with every single exhale.
I didn't realize why that was so crucial until I read the breakdown. If she's exhaling CO2, it proves the chest compressions are successfully pushing blood through the lungs to exchange gases.
Exactly. It's real-time proof that their manual pumping is keeping her viable.
Amazing. I also noticed a guy just sitting on the couch in the background. I honestly thought he was a family member, just in the way, but he's the scribe.
The scribe has one of the most important jobs in that room.
Really. In the middle of all this life or death action, his entire job is just to sit there and take meticulous notes. He documents every microgram of a drug given and gets the medical history.
You just cannot rely on human memory when adrenaline is spiking at a chaotic scene like that. Documentation is absolutely critical for the hospital team waiting for her.
Now, here's the part of the footage that completely threw me. At one point, a paramedic pulls out a literal drill.
Ah, the IO drill.
Yes, an intraosseous drill, and they drill a hole straight into the patient's shin bone to deliver drugs. Why on earth are they drilling into a bone instead of just starting a normal IV in her arm?
You have to think about the physiological reality of total circulatory collapse. When your heart stops, your blood pressure instantly drops to 0. So your peripheral veins, the ones in your arms and hands that we normally use for IVs, they turn into flat, empty balloons. They essentially vanish. You cannot thread a needle into a collapsed vein.
Oh, wow. I never thought about that.
Right. However, the bone marrow cavity is a rigid, non-collapsible matrix of blood vessels. So drilling an IO line provides the fastest, most direct highway straight into the central circulation.
To deliver life-saving drugs like epinephrine.
Exactly.
So they push the drugs, they deliver a shock, and incredibly, they get a pulse back. ROSC, return of spontaneous circulation.
It's always a huge relief.
But the video doesn't end with high fives and her waking up. They actively choose to put her into a medical coma right there on the living room floor.
They have to. Allowing her to wake up immediately would be devastating. Her brain has been starved of oxygen. Waking up dramatically increases the brain's metabolic demand, meaning it needs significantly more oxygen when it's conscious.
And the body just can't provide that yet.
No. That sudden demand can cause severe secondary brain damage. So they administer ketamine to put her to sleep.
The source specifically noted they chose ketamine over other sedatives because it doesn't cause blood pressure to drop, which she obviously desperately needs to maintain right now.
Right. And they paired that ketamine with rocuronium, which is a paralytic.
To paralyze the vocal cords.
Exactly. By paralyzing her vocal cords, they can safely slide a secure breathing tube down her trachea without her gagging or vomiting. It completely protects her airway for the transport.
Okay, so she's stabilized on the floor, but that blocked pipe, the original cause of all this, is still blocked.
Yeah.
The compressions just bought her a window of time. What happens when she hits the ER doors?
Well, they actually bypass the ER entirely and head straight for surgical intervention in the cath lab.
For a PCI, right? A percutaneous coronary intervention.
Yes. A cardiologist threads a catheter up through an artery, inflates a balloon to physically crush the plaque against the artery wall, and deploys a metal stent to keep the pipe open.
And hospitals operate on a super strict window for this, right? Like 90 minutes from the time the patient arrives to getting that balloon inflated.
90 minutes, and if the blockages are too severe or calcified for a stent, they have to pivot to open heart surgery, a CABG.
Where they use a healthy saphenous vein from the patient's leg to surgically build a bypass route around the clogged artery.
Exactly.
There is a massive caveat with the cath lab procedure, though, that jumped out at me from the simple nursing source. To actually see the blockages on the X-ray, they inject an iodine contrast dye.
Yes, contrast dye is essential for imaging.
But the source described this dye as being incredibly thick and viscous, like dumping cement into the body's washing machine.
That viscosity is an absolute nightmare for the kidneys. Your kidneys rely on these microscopic filters to clean your blood. Forcing that thick, heavy contrast dye through those tiny filters really strains them to the breaking point.
Which is why aggressive hydration before and after the procedure is mandatory.
Right. The nurses have to constantly monitor the patient's creatinine levels to ensure the kidneys aren't shutting down.
They even have to completely stop certain diabetes drugs, like metformin, right?
Yeah, because if the kidneys are struggling to clear the dye, they won't be able to clear the metformin either. And that leads to a toxic buildup of lactic acid in the blood.
Treating one failing organ frequently compromises another. It's just an agonizing balancing act.
It is. And that balance is maintained in the ICU using a very complex array of IV drips, known as the pharmacopoeia.
I was reading the Lippincott update on these ICU drips, and it's basically like a live chemistry experiment.
It really is. They generally fall into 3 categories. You have vasopressors like epinephrine and norepinephrine, which clamp down the blood vessels to physically force blood pressure higher.
Okay.
Then you have inotropes like dobutamine and milrinone, which chemically force the heart muscle to squeeze harder.
Right.
And finally, vasodilators like nitroglycerin, which relax and open the pipes to lower the heart's workload.
Wait, I'm looking at dobutamine right now. It forces the heart to beat harder. If the heart just suffered a massive trauma and half the tissue is dead or dying from a lack of oxygen, isn't making it work harder the exact opposite of what you'd want?
It seems counterintuitive, doesn't it?
Yeah, it sounds like whipping a tired, dying horse.
It is exactly like whipping a tired horse, and it is incredibly dangerous. Forcing damaged myocardium to work harder dramatically increases its oxygen demand, which is the very thing it lacks.
Right.
Doing so can easily trigger deadly arrhythmias, like ventricular tachycardia, throwing the patient right back into cardiac arrest.
So why use it at all?
We only use inotropes when the alternative is immediate total cardiovascular collapse. It is a calculated, desperate risk when all other options have failed.
The margin for error with these drugs is razor thin. I found a terrifying example of this in the Medics corner source regarding nitroglycerin.
Yes.
It's a standard vasodilator used everywhere for chest pain. But if a patient has suffered a right ventricular infarction, meaning the right side of the heart is the part that's damaged.
Giving them nitroglycerin will completely crash their blood pressure and put them into shock.
Why does that happen?
The mechanism behind that is really fascinating. The right ventricle is a low-pressure pump that relies entirely on the volume of blood returning to it from the body to pump effectively. It needs that fluid pressure known as preload.
Okay, and nitroglycerin dilates the veins.
Yes, it dilates all the veins in your body, causing blood to pool in your legs and arms. That starves the damaged right ventricle of the fluid volume it desperately needs to function.
The pump runs dry, and the system crashes.
Exactly. Precise diagnosis of which specific wall of the heart is injured dictates every single move you make.
We're talking about incredibly high-stakes interventions here. I mean, drilling into bones, inflating balloons inside arteries, managing a terrifying balance of chemical drips. The overarching question has to be, how do we avoid ending up on that living room floor in the first place?
That brings us to the 2025 hypertension guidelines detailed in the American Nurse Journal. The medical community is shifting to a much more aggressive preventative stance.
Normal blood pressure is now strictly defined as anything under 120/80, right?
Yes. Anything above that threshold is officially elevated and requires intervention.
The fascinating part of this update is that controlling blood pressure isn't just about protecting the heart from a blowout anymore. It's deeply connected to the brain.
The new guidelines really emphasize the long-term mechanism of high blood pressure on cognitive function. Chronic hypertension physically degrades the tiny, fragile microvessels deep inside the brain.
So over time, these microbleeds and areas of poor circulation just compound.
Exactly. There is an undeniable physiological link between long-term high blood pressure and cognitive decline, including vascular dementia. Guarding your blood pressure in your 40s is how you protect your memory in your 80s.
To help predict these risks, the guidelines introduced the Prevent Risk Calculator to map out a patient's 10 to 30-year risk of heart disease. I was looking through its metrics, and one of them really threw me.
The social deprivation index.
Yeah. I understand factoring in blood pressure, cholesterol, kidney function. But the Prevent calculator uses a social deprivation index based on your ZIP code. How does my address biologically affect my heart risk?
It's a profound acknowledgement of the social determinants of health. If your ZIP code correlates with unstable housing, lack of access to fresh food, or living in a state of chronic socioeconomic stress.
Your stress levels are just constantly elevated.
Exactly. Your brain's amygdala is constantly firing. Your body pumps out stress hormones like cortisol continuously. And over 10 to 30 years, that relentless flood of cortisol physically inflames and degrades the endothelial lining of your arteries.
Wow. So your environment literally alters your biology.
It does. The guidelines emphasize that you can't just hand a patient a pill. Treating hypertension requires a customized, team-based approach, including social workers, to address the root environmental causes.
It's treating the entire human ecosystem, not just isolated plumbing. Now, for the patients who do survive the ICU and are lucky enough to be discharged, the Simple Nursing Source provides a highly memorable acronym for their recovery: DRESS. D-R-E-S-S.
It's an excellent framework for patients navigating what are essentially overwhelming lifestyle changes. D is for diet, specifically prioritizing low sodium and restricted fluid intake to prevent overworking the healing pump.
And R, reduce stress and cholesterol. The clinical guidance is heavily geared toward plant-based or fish diets, moving away from land animals, right?
Yes. E stands for exercise, gradually rebuilding cardiovascular endurance. S is smoking cessation, which is totally non-negotiable for vascular health.
And the final S is sex, which the source notes is a surprisingly common question from recovering patients.
Well, it requires significant exertion, so patients need a practical, measurable milestone to know when their heart can actually handle that level of demand.
The clinical rule of thumb provided is the stairs test. You can only resume that particular activity after you can successfully climb 2 full flights of stairs without losing your breath.
Yeah.
If you can't do the stairs, you can't do the what? Well, you get the picture.
It's a reliable, self-administered test for cardiac endurance.
We have covered an immense amount of ground today for you all. We took you from the cellular mechanisms of plaque ruptures and dying muscle fibers to the chaotic, bone-drilling heroics of paramedics running advanced life support algorithms.
We covered a lot, yeah.
We navigated the razor-thin margins of the ICU's chemical drips and finally brought it back to the daily habits, the blood pressure goals, and even the ZIP codes that dictate our long-term health.
The biological heart really is an astonishing piece of machinery. But reviewing these sources actually leaves us with a provocative thought regarding its future.
Oh, well, what's that?
Well, we've spent this entire deep dive discussing how to repair the organic pump. Stents, bypass leg veins, chemical whips. Yet our sources also briefly highlight ventricular assist devices, which are mechanical pumps implanted directly into the chest.
Right, the technology is moving so fast.
The engineering behind these devices is advancing exponentially. It begs the question, how close are we to a medical era where we simply stop trying to repair the biological heart entirely?
Wait, really? Just bypass the organic part altogether?
If the plumbing is irreparably clogged and the muscle is dead, what happens when we can just replace it with a flawless synthetic machine? We are rapidly blurring the line between human biology and advanced engineering.
That is wild to think about.
It is. What does it mean for our humanity when the most vital organ in our chest comes with a battery pack and a warranty?
That is a staggering thought to end on. When the city grid fails, maybe the future isn't patching the old wires. Maybe it's just installing a fusion reactor. Thank you so much for joining us on this deep dive. Keep questioning, keep learning, and most importantly, take care of that incredible city grid in your chest. We'll see you next time.